So I'm going to introduce Dr. Simin Beg, who has been just a very important palliative force in this community, and just delighted to have her supporting our fellowship activities here in the region. And so with that, Simin, go ahead and take it away.
Good morning. Sorry for the delay in the start. So we're gonna talk. We're gonna talk today about palliative care and heart failure. I really really love. This is my. Can I even say it's my favorite cohort of patients. No disclosures. We're going to really talk about what heart failure is, the role of palliative care in heart failure, some of the barriers that we're seeing, and then even some special considerations like a removal of advanced mechanical therapies and even lifestyle medicine interventions. I'm not going to go through this in detail. I know you all know what heart failure is. The point here is to recognize that heart failure is actually it's a syndrome with multiple symptoms, and there's even different reasons and causes for heart failure. Nonetheless, the bottom line is that there's just an inability, whether it's a structural or functional inability for the heart to beat, the ventricles to fill or eject the blood. It is increasing. The prevalence of heart failure is increasing. About 6.2 million adults in our country now have heart failure, a lot. Just a few years ago, 2018, it was over 13% of the cause of death in death certificates, and it is very, very costly for our healthcare system. It is the most common cause for the 30-day readmission rate. As you all know, hospitals are being held accountable for that. And like I said, just very costly for our healthcare system. The disparities in heart failure are actually increasing. The racial and ethnic disparities are present for hospitalizations, for all types of interventions. And again, like I said, that's increasing. The demographic that is on the that is most are Black men. There's multiple studies that show that. Part of the reason is that some of the research that's done is really not focused on all of the populations of people that we're trying to serve. So that does create a barrier. So in order to address those, we really do have to look at the structural interventions regarding the social determinants of health, and even do things like implicit bias training with our teams, which that is now becoming more prevalent in all areas of medicine. Just a quick slide on the addressing the barriers. I'm not going to focus on this too much, but you can see that addressing the disparities in heart failure would require a lot of systemic interventions. Everything from diversifying the workforce so that the healthcare team looks more like the communities we serve, to finding more diversity in research, and then also even just removing barriers to heart failure referrals. And we're going to talk about that. And all of this is a multimodal intervention to addressing disparities. Again, a very complex issue that requires a complex situation or intervention solution. I know you all are aware of the New York Heart Association functional classification. Of note, we tend to deal with the class 3 and 4 primarily, whether it's hospice or palliative care. But just for your awareness, of the difference between 3 and 4 is that 4 has symptoms at rest, even things like conversation or turning in bed. 3 is they're comfortable at rest, and any ordinary physical activity results in symptoms of dyspnea or chest pain or fatigue, any of those symptoms. In addition to the class, there is a stages of heart failure. You are probably seeing this more and more. Cardiologists are really using this much more than the New York Heart Association class, and that's because a New York Heart Association class is subjective. If somebody comes in decompensated CHF, they may be in New York Heart Association class 4, but you diurese them or get their blood pressure under control, and they may be reduced to a 3 or 2. So for our work, a patient's New York Heart Association class can fluctuate. The stages of heart failure, stage A is when patients are at risk. This is where lifestyle interventions and medicines can be very, very helpful. Stage B is when they do have structural heart disease, but they really don't have symptoms. Stage 3 is when they're having symptoms, or they've had symptoms and those symptoms have resolved. And stage 4 is when those symptoms are persistent. So a lot of times you'll see the cardiologist combine the stage and the New York Heart Association class. The trajectory of class C, that is where there's structural heart disease and either they currently have symptoms or they had symptoms and they've been resolved. Really, the trajectory, oops, sorry. The trajectory, ah, um, is either the language that we use regarding this is persistent heart failure or worsening heart failure. You know, even when a patients with heart failure, their symptoms have resolved, we don't say that heart failure has resolved. We say that it is in remission. And when they come to that, when they reach that point of class C, full remission of, of, of their symptoms is actually quite uncommon. They really will have consistent symptoms once they hit that class C. So this graph kind of shows you the overlap between the stages and the New York Heart Association class. You can see that the C can be anywhere from 1, 2, 3, or 4. Kind of speaks to the point of why the stages are being used much more than the New York Heart Association class. But when you hit to the stage D, you typically are a class 4 and sometimes a class 3. Classification of heart failure by LVF. We used to use systolic, diastolic, and know in our hospice care, we still do use that terminology. That is really falling out of favor in cardiology. We tend to classify heart failure by the LVF. And if it's less than 40, it's reduced EF. If it's greater than 50, then it's preserved EF. In between, there is a mild LVF, EF, heart failure with mildly reduced EF, and with improved. So again, not calling the heart failure resolved. If it's improved, it is heart failure with improved EF. It's a kind of a mouthful to say. As you can see, I'm kind of stumbling over my words, but this is the classification that is, again, much more accurate than the diastolic, systolic. Over the course of time, you can see that the quality of life in this top graph, the graphs go in the opposite, or the lines go in the opposite directions when you look at disease-modifying therapies and the quality of life. Just as the quality of life tends to decline, no surprise there, as there are more disease-modifying therapies. And here is where you can either consider mechanical circulatory support like LVADs or hospice care, really having watching that trajectory all along really is important to do. The prognosis of heart failure is a little trickier than it is in oncology. And we do have some models, patients with chronic heart failure, whether it's EF preserved or reduced or moderately reduced. You can use a Seattle heart failure model. The link is here. MAGIC is another one. Specific to reduced EF heart failure, you can use guided. I'm going to be honest, I tend to not use these as much unless I have a patient who really wants to know this. A lot of our prognostication comes with that prior graph that I showed you with the disease trajectory. I do use this from time to time, but I don't use it with every patient. Just wanting you to be all aware. Um, what the recommendations are for involvement of palliative care and supportive care, you know, the the level of recommendation having palliative care involved for clarifying prognosis, goals of care. This is we all know it. We all know it. But this is something that is been recognized by the American Heart Association and the American Association of Cardiology that when patients do have heart failure, and it doesn't even say advanced heart failure, but when they have heart failure and they are being considered for or treated with any type of life extended therapies, getting palliative care and supportive care involved as a level one um, recommendation is widely present in the literature. There are not a lot of studies around that, and but the recommendation is still level one. Um, for patients with stage D, uh, in having palliative care consulted for those patients does show to have better outcomes. There have been studies around this, but the recommendation is a 2A. Again, that really speaks to really the studies that have been done. We really need more studies done in this area, but nonetheless, it shows that for heart failure patients, having palliative care involved can help with quality of life, can help with disease, with symptom burden, and a timely referral to hospice. So again, 2A recommendation, still limited studies, but that is the consensus amongst our cardiology peers. So what can a palliative care do? I mean, it's the same thing that we do with every patient. High quality communication, that really is one of our best, one of our highest skills, I would say. Talking about the prognosis, and even though the prognosis in heart failure is a little bit challenging, as I previously said, that health literacy piece that helps patient understand what's going on. Heart failure is quite complex, and so we can really be helpful in helping with that health literacy piece, and therefore being able to prognosticate much better. And when we do that, clarifying those goals of care of conversations at every juncture when there's a new decision or a new treatment that's being considered, when there is any change in patient's condition, just clarifying those goals of care. Again, we all know this. Um, the shared decision making at Carlisle Health, we use the head, heart, hands. You all have heard me present on that, the 3 questions, with a real emphasis on health literacy. In case you all didn't know it, October is Health Literacy Month, so um, I'm going to bring that up as much as I can. Again, 12% of our patients actually have low health literacy, so focusing on that as we go through the shared decision making, with our patients. Symptom management, a, a, a lot of a lot of symptoms in heart failure that as those symptoms are better managed, they respond better to therapy. And studies have shown that they live up to 3 months longer when uh, when we have hospice palliative care involved. And again, because the trajectory of heart failure is tends to be much longer, that caregiver support is also really helpful. The difference between, palliative care really did originate from oncology, and there are some, differences between palliative care involvement in oncology and for heart failure. Well, one of the things is that the time of referral is a little bit is a little bit trickier. In oncology, it can be a little bit clearer. So when the therapies have been exhausted, when we're on to the second, third, fourth line of chemo, you kind of get the idea that we're entering into that last 6 months of life. With heart failure, you can go back and forth from the classes from 4 to 3 to 2, depending upon what interventions are being used. So that last 6 months is a little bit harder to discern. The trajectory is not as linear as it is in oncology. There's a lot of exacerbations and remissions, which again makes that challenging. The care setting, because the trajectory is a lot longer in heart failure, you tend to see patients living in nursing facilities for a longer period of time. Palliative care, we do have clinic. I do see patients in clinic, but the ambulatory clinics are not as prevalent as they are in oncology. Um, and the medical therapies, again, in oncology tend to be a little bit more straightforward, whereas in cardiology, there are many therapies that can start from the time of diagnosis all the way to the end. Um, and the caregiver burnout in heart failure, again, just because the trajectory is so much longer, tends to be much more prevalent as well. So these things do add a layer of complexity to the involvement of palliative care in heart failure. Some of the common symptoms that we see in heart failure, we're going to talk about what those symptoms are. Dyspnea is just by definition part of what we see in heart failure. Um, Addressing the symptoms in heart failure, the overall philosophy really does go back to trying to manage the disease more effectively, looking at the cause of those symptoms, and trying to address those symptoms from the root cause. So the number one intervention to dyspnea is looking at the cardiac medications and diuretics. Opioids would be something that we use, but after we've looked at, has this patient been medically optimized from their dyspnea perspective? Is their blood pressure better in good control? Are they volume overloaded? And looking at those pieces before we start opioids. Opioids are very effective and can be very helpful. Really no evidence for oxygen unless the patient is hypoxic. And benzos are second line therapy after we've tried to medically optimize them and use opioids. Inotropes can also be very effective for helping address the symptoms of dyspnea. Depression is very, very common in heart failure. About 20% of the patients have major depressive disorder, and even more than that just have plain depression. Obviously, we see this in chronic diseases. Chronic diseases and depression really go hand in hand. SSRIs are the first line that we tend to use. You can use an SNRI like duloxetine if patients have pain as a part of it, so trying to combine symptoms. Avoid TCAs, even for our younger patients, if they have neuropathic pain, they can be very effective just because they tend to cause prolonged QTC in our patients with heart failure. So really try to reduce or avoid the use of TCAs. And really using the non-pharmacological interventions that we tend to overlook, as they can be very, very effective. In fact, there are some studies that show that they can be just as effective as SSRIs in dealing in trying to treat depression. So really focusing on that. They can be a little bit harder because they don't work as effectively, and they do take a lot more time sometimes from the provider standpoint. Pain is the most common symptoms in heart failure, and the prevalence of pain increases as the New York Heart Association class increases. When patients get to a class 4, about 90+% of them actually have pain. It is okay to use opioids in dealing with pain, even if the patient is not in end of life. We don't really use opioids in heart failure as much as we do in oncology. We really want to make sure that we're addressing the pain issues. If pain is concurrent with depression, as I said before, trying to use an SNRI to address both symptoms. And again, the non-pharmacological interventions are very, very effective. We're going to talk a little bit about those um, in a bit. Fatigue, this is trying to address the secondary cause of fatigue. Is it insomnia? Is it OSA? Is it anemia? Um, you can use things like cardiac rehab, again, very effective, and exercise. Sometimes we do use stimulants, but you got to really use them cautiously, again, because of the heart disease. So I have used stimulants like Ritalin at low doses. Again, tend to use them in younger patients and avoid them in advanced heart disease, but they can be used. And then really using our IDT to address the symptoms of isolation, challenges navigating the healthcare system, uncertainty around the prognosis, and just that disease trajectory that can be, a lot of remissions and, exacerbations of the heart failure, really using your IDT to help support patients and their caregivers. Some, lifestyle medicine, you all know that I took the boards. I think it's been almost 2 years now. But lifestyle medicine really did originate out of cardiovascular disease. And it is underutilized in our heart failure population. And really, it can be a very effective way. There have been some really compelling case studies where patients have gone completely whole food plant based and have been able to get off of all insulin, all cholesterol medication, blood pressure medication. I mean, very, very strict whole food plant based, using no animal products at all. Very hard to do, but nonetheless, if a very effective and evidence-based intervention. So, as we're managing our heart failure patients in palliative care, managing heart failure disease will also help with managing their symptoms. So sometimes, I mean, I've been asked by people that, when patients when we're seeing them with advanced heart failure, is that really the time to talk about whole food plant-based diets? And I would say it absolutely is, because there is a moderate benefit for patients that have stage A, where they have the risk, certainly, but there are also potential benefits all the way to the stage D. So really kind of gauging your patient's interest in, are they willing to have a conversation about changing their diet? And it doesn't have to be an all or none. I had a patient that I saw a few weeks ago, and he loved hot dogs, so he had 2 hot dogs in the morning and 2 hot dogs at lunch and 2 hot dogs for dinner. Now, this was not a patient that I was going to talk to about a whole food, plant-based diet, but I did talk to him about reducing the hot dogs, so maybe having 1 hot dog at breakfast, lunch, and dinner. So starting that conversation, about the whole food plant-based diet. Sodium restriction, again, uh, it is beneficial for symptoms when patients have, issues with blood pressure control and edema. Looking at again the dietary intake of sodium and providing that education. It is there's a great website with the American Heart Association regarding sodium and salt, but really patients do not know how to look for sodium in their diet and where this can kind of sneak in. So providing that education. Um, Exercise, this has a strong benefit in all stages of heart failure, even in stage D, class 4. This is really dependent upon what the patient can tolerate, things like a stationary bike, pool walking, whatever the patient is able to do. Last week in our heart failure clinic, Megan, who was with me, she's one of the nurses, she suggested just one of those, you know, pedals as a patient sitting on his couch, he can just be moving his feet, which I thought was a great idea. The patient was able to order that off of Amazon for like $60. So again, emphasizing the benefit of exercise. And then some of these non-pharmacological, the mind-body association. The reason why we are, you can see it says it's weak in all stages of heart failure, and that's because We just don't have the studies. If you look at the studies that are done in just a small number of patients, and we've just not studied this as extensively as we've studied medication, but there have been absolutely a great benefits shown regarding symptom burden and quality of life. Now, it requires a patient to buy into that. It's not immediate. Um, and again, some patients, I do always bring this up. Some patients literally roll their eyes at me visibly, and others follow along. There's many ways to do this. You can do it online with apps, classes. Again, really engage assessing where your patient is and their willingness to try this. But I bring this up, we talk about bringing up smoking cessation in every visit. I bring up the non-pharmacological lifestyle interventions at every visit because you just don't know when a patient is going to be agreeable or when they're ready. So I do bring this up. Some of the supplements that we see, there have been really no evidence showing that they've been beneficial. Coenzyme Q10 has slightly more compelling evidence, but again, there's just not been enough studies to recommend that. If my patients are on it, unless it is something that I don't know or can be harmful, I don't take them off of it. But again, just not enough evidence to recognize this. Here is something, another non-pharmacological intervention, thermal vasodilatation using a portable infrared thermal blanket. Now, the infrared saunas, they have been getting a lot more popularity for chronic disease management. This is a study, it was a very small study, only it included 38 patients, but these patients, they had decompensated heart failure and they were on dobutamine. And what they did is they took these patients and they divided them into two groups, one who received, regular therapy, and then one who received the therapy and also underwent vasodilatation using a thermal blanket at 122 degrees for 40 minutes. And what they found is that those who used the thermal the blanket, they had a increased cardiac output and reduced vascular resistance. And so this, I mean, again, very small study, 80+% of them were men. Again, we would need a much bigger study, but I'm going to talk about a patient where I did make this recommendation. This is really compelling. The data around the sauna infrared blankets actually even shows to increase or to reduce the recovery time after exercise, to actually increase insulin sensitivity. So, something that does not have a lot of side effects. 122 degrees, that's not a big deal for me. I was raised in Pakistan, so I can handle that quite nicely. But something to really think about as we look at trying to use non-pharmacological interventions for our patients with heart failure. So how do we do this? As you saw in the earlier slide, that the recommendation to involve palliative care is at the time of diagnosis, and certainly when patients reach that stage C, D, um, uh, and New York Heart Association class 3 and 4. But we know that that is not the case, even though the American Heart Association and American College of Cardiology all recommend that. That is not what happens. There are a lot of reasons for that. I would say a part of it is it's just not how it's been done, and creating a new behavioral process just takes new synapses in the brain. So some of the things I've been working in the heart failure clinic. I think it's been for 9 years now, maybe. And we've just seen some ups and downs with it. It's not been as a straightforward and as like it has been in the oncology side. But what we found is that in order to really get palliative care involved with our heart failure population, we really got to remove the friction for the referral process. I am still, you probably heard me say this last time, I am still a huge advocate for the opt out, that when patients are admitted or when they start are being seen by the advanced heart failure team, that palliative care should be an automatic. It should be an opt out, not an opt in. Just making that referral process easier. We're not quite there yet, but making it easier even in the inpatient setting. How easy is it to think about their palliative care partners, and how easy is it to make that referral process, again, removing that friction. Collaborate I would say that has been the most effective thing. And it's not just with the physicians or the clinical team. Our operations team has been very, very effective at collaborating with the operations team of the advanced heart failure clinic. And in fact, I think they actually got a uh, better traction when they eliminated the physicians for a few of their meetings. But that collaboration is absolutely critical, really listening to the cardiology team as to what their need is, what barriers are they seeing, and to remove those barriers, and having those ongoing collaborative meetings, so that we can understand what their needs are. Developing criteria and automatic triggers, so that it's not subjective, that working with the cardiology team, there's not a lot of data around a consensus around what those trigger tools are, but really working with the cardiologist and their team to, what does it make sense? It really does make sense to have an automatic trigger when patients are at the stage D, class 4. But even prior to that, what other triggers can be used? And we really do not need to change the name. I know that there are a lot of institutions and healthcare organizations that use supportive care instead of palliative care. And part of that is because of the misconceptions, not just for our patients, but for our peers. When they hear palliative care, they hear something that it's not. You're going to find people who disagree. I think that instead of changing the name, I think providing robust education around who we are and what we do and what benefit what we can offer. But again, those are just some of the recommendations. In the inpatient, in our inpatient patient population, here are some of the primary criteria for palliative care referral. The surprise question. I know you all are familiar with that. Would the attending be surprised if the patient died within 12 months? Frequent admissions. That is a really a great trigger. Any type of uh, difficult to control symptoms, or any type of psychological symptoms, social determinants of health as we're trying to address them, complex care requirements, or any time that there is a decision to be made, a decline in function, a decline in the PPS. These are really great times to get palliative care involved. And we have been educating our cardiology counterparts um, regarding these criteria for referral. Some of the secondary criteria, if they're coming from a long-term care facility, if they're elderly, they've got a local or incurable cancer, use of oxygen dependency for ADLs, all of those kinds of things also would be secondary criteria for getting palliative care involved. I want to talk about a couple of things that are unique to taking care of patients with end stage heart disease. This was a patient, fairly young patient, 59-year-old with ischemic cardiomyopathy with an LVF of 12%. They were hospitalized for cardiogenic shock, and milrinone was started, and wanted a heart transplant, but they were just not a candidate for a heart transplant. So instead of a heart transplant, they were evaluated for an LVAD, which they did receive. And the LVAD was destination therapy, so they knew that there was just not going to be something beyond that. They also knew that at some point when there were complications around the LVAD, that would, you know, that would enter them into an end of life situation. Patient initially did well for several months, but then suffered a CVA, and was bedbound, and just did not have the quality of life that they wanted. So uh, our palliative we I had been following this patient in clinic, as he had an LVAD, but then after the CVA, he was not able to come to clinic because he was bedbound. We did get our home palliative care team involved, because initially the patient did not want hospice involved, even though it was very hospice appropriate. And really, our home palliative team was not involved for very long. The biggest intervention they did was just have that complex goals of care conversation with the patient and the family around. And the patient did elect to deactivate the LVAD, did not want to continue living the way he was living. And so we got our hospice team involved to do the LVAD deactivation. And so the LVAD deactivation, you will see from time to time. I would say we probably do maybe 6, 7 a year, maybe more than that, but definitely it's not something that we do just on a rare occasion. It is something that we do, and the and I know that there's a lecture regarding event removals, and LVAD deactivation is very similar to event removal. We follow all of the same protocols and even the same medications. There are some things that are going to be a little bit different, and I'm not going to go through the common parts of event removal, um, I- but I will go through some of the things that are a little bit different. You want to coordinate with the LVAD RN, because each LVAD is a little bit different, and you want to make sure that the alarms are turned off, because when the LVAD is deactivated, the alarms can go off, and that can be very distressing with the family. And again, because there's different LVADs, you want to make sure that the LVAD is appropriately turned off. So coordinating with the LVAD clinic and the LVAD nurse, and making sure that the LVAD is turned off. Want to provide that education for the patient and family, and really do have the DNR DNI status documented and signed. So that education piece, just like it is for vent removals, is really important. The survival after LVAD deactivation can be anywhere from minutes to days. So providing the patient and the family with that education, and other life-sustaining treatments, like if they're on dialysis, or if they're on TPN or tube feeds or anything of that of that sort, those things should also be discontinued at the time of LVAD activations. Having both sub-Q and oral medications available is what is recommended in the literature, and I'm going to say we typically use the sub-Q route. We don't really use the oral route, just because it takes longer to take effect. And it's really important to give a bolus of opioid and the benzos prior to turning the LVAD off, because the LVAD is a circulatory device, and so letting those medications circulate, um, uh, you know, before the LVAD is turned off, so that patients can get the benefit of those medications. You want to monitor the symptoms closely. Again, titrate the medications as needed, and really have the IDT present there to support the family, as this can be really distressing for the family. So, in my previous slide, you might remember that we talked about the disparities in heart failure and how they're increasing. and really looking the way to address those disparities is some of the personal work that we do. You've heard me talk about the cultural humility, and that is absolutely critical. But in addition to that, looking at the systemic um, uh, um, our resources as a way to care for patients with heart failure. And this patient, this is a couple years old, and Dylan Drummond, who is now one of our partners, who was a fellow at the time. But this was a 69-year-old Black woman who had multiple hospitalizations and missed multiple clinic appointments. She had been on my schedule in the heart failure clinic for months and months, and I think she had 8, 9, 10 missed appointments. She had combined CHF, LVF of 10%, history of diabetes, and she had been struggling with housing insecurity for quite some time, on and off. When we saw her, this was in September of 2022, I think. She had been living right outside the downtown market in tents, and when that area got cleared up, she just didn't have a place to live. So that was really challenging for her. A lot of psychosocial factors, obviously, as she's struggling with housing insecurity, really was challenging for her on many other levels, and had multiple symptoms with pain and dyspnea. And it was for these symptoms that she would show up into the ED, would often get diuresed, or her blood pressure she would maybe be present in hypertensive urgency. And anyway, that is kind of how she showed up. The She was hospitalized, and then we got called and said, this is the patient that you that's been on your schedule. Can you come see her? She's in the hospital. So we did go see her. And, started with that goals of care conversation and health literacy piece. And I will say that she actually really had a really good understanding of her disease process and treatment options. She knew what her heart failure was. She knew what made it worse. She knew what made it better. Again, my own bias with, I thought, oh, she doesn't understand. She actually understood quite well. When we asked about what she hopes for, she really just hoped for some stable housing. She knew what she needed to do to manage her heart failure, but she just didn't have a place to do it. She said, I can't really take my scale, as I'm living in a tent. And, as we were aligning the two, what steps do we do next? It wasn't really about medication, but it was really about trying to figure out a stable housing situation for her. So we did a cost analysis, reached out to our leaders at Corewell Health, because we do not have a mechanism to help patients with housing. She was provided housing. She initially and did accept hospice services, and actually passed away in 4 months after we got involved. But we saved our healthcare system close to $700,000, looking at just helping providing her housing. So not only did that address some of the disparity, we didn't address the disparities all the way to when we got involved, but helping her with housing definitely helped with her symptoms, and help the healthcare system. I really, I know we're getting close on time. I'm going to um, I'm going to do this patient real quickly, because she was a 77-year-old woman who I actually just saw not that long ago. I would say within the last few months. A history of diabetes, very mild. Her A1C was like 7.2. Uh, Ejection preserved EF with an EF of 55. So New York Heart Association class 2 to 3. So I had been seeing her in the heart failure clinic, but she started to have more hospitalizations for decompensated CHF. And the interesting thing about this patient is her code status was revolving. Sometimes it was full code, sometimes it was DNR, sometimes it was, I don't even want treatments. So really revolving code status. She lived independently at home, and both times that she was hospitalized, they did recommend home care or home palliative care, and she refused. She did not want any help in her home. She did not feel like she needed it because when she was a New York Heart Association class 2, she was able to take care of herself adequately. So when I saw her in the clinic, um, she did not lack resources. She definitely could have hired even in-home care, but just did not want that. But was very motivated to stay independent in her home for as long as she possibly could. And I pulled out my lifestyle medicine board certification kind of hat on and talked to her about some of the dietary changes that could, help her manage her heart failure. We know that heart failure with preserved EF is really a medical disease that, if you manage blood pressure better and diabetes better, that will manage the heart failure better. It's very different from the systolic or the ejection fraction reduced heart failure. So talk to her about whole food plant-based diet, reducing her sodium. And she was very interested. She said, if this works, I'll do it. But, and I know that she had been told that before, but, she did not remember when these lifestyle interventions were discussed with her before. But the interesting thing is because she was so eager, I brought up the sauna blanket and I shared with her just the limited studies. I shared with her what we don't know, but I did share with her that this could be effective not only for her heart failure, but perhaps for her diabetes. She was on just a small dose of metformin, and I suggested that to her. She, while she was in the clinic, got on help. She asked me to help her again order that from Amazon, which we did. And it was delivered to her and she started using it. She was not able to do the 40 minutes as that study showed. And and again, I don't know this, but I said 20 minutes 3 times a week should be fine. I kind of went with the exercise, if you do that 3 times a week. So she had been using that 20 minutes 3 times a week, slowly building up her tolerance. And her symptoms are much better. Her diabetes is much better. She would like to go off of her metformin, which I encourage her to talk with a cardiology about that. But the thing that her mood, her is just significantly improved. So I wish I had enough patience where I could do a study on this. And I do try lifestyle medicine interventions, and this was just such a pleasant patient to see. Her revolving code status actually resolved. She did sign the DNR. She still has not let our home palliative team in her home. But I see that as that trust builds, we will be able to serve her, particularly as she declines at some point. So this was just a kind of a fun thing. Um, so anyway, takeaways, it's a syndrome, it's unpredictable, it's progressive, a lot of symptoms. You got to have the goals of care to address the pain, interdisciplinary team approach. And one thing I should add is lifestyle interventions for patients at every point in their trajectory of heart failure is very, very helpful. So just opening this up to any comments or questions. Sorry, I had to reduce the presentation due to our late start, but would love to hear any comments you all have. I can stop sharing my screen now.
Well, thanks, Stevie. This is wonderful, as I anticipated it would be. I'm very, very intrigued to learn more about the kind of the heat source and how that actually helps. And so it'll be interesting to see future studies on that. One thing I just wanted to revisit and give you just a chance to respond. You had sort of mentioned the 3 questions, head, heart, hands. And I've heard you, relate that before, but I'd like you to do that just briefly here, because we have a lot of new fellows that may not have had the opportunity to hear you.
Oh gosh, yes. So the head, heart, hands model, I mean, it's something that actually all good physicians do. And most of them may not even realize they're doing this. This sort of just came out of Watching really great people, John, like yourself, do goals of care conversations. I was early on in my career, and doing it well sometimes myself, and failing. I've done such poor goals of care conversations and reflecting on what went well, what didn't go well. And really what it came down to is the head, heart, hands model is the really the only way we should be providing healthcare, and it is the best way to provide equitable care. I have a whole lecture on this, so I'm going to do the really short version. It starts with the head, it starts with health literacy, and their questions are not statements. You have to ask your patients, tell me what you understand. And the reason why is because when we tell our patients all the time, even that patient, that last patient, she said, nobody's ever told me about lifestyle medicine interventions. I know that's not true. But when you ask, it creates a dialogue. You get a chance to understand your patient's language, how they're verbalizing their understanding, helps you understand the language you need to use, and helps you identify knowledge gaps. So that's health literacy. So you understand about your disease and treatment options. Then after that, you go to the heart, which is, now that you know that, tell me what you hope for, what you fear, what makes you you, what your values are, so that I can understand who you are. We don't get to have an opinion about this piece. We can ask clarifying questions, but this is us sitting with our patients with cultural humility and hearing what they value. Then the last one is, how do I align the two? This is the hands. What things do I need to put into place so that I can honor your hopes, your fears in light of your reality? And this is where the doing part comes in. This is where we can guide our patients. That, well, if this is what you're hoping for in your reality, full code is not going to get you there. I'm here to guide you so that you can get what your goals are in light of your reality. I'm not here to tell you how to live your life, but this is where we can guide our patients. This is where we create partnerships. And our patients that was struggling with housing insecurity, this is where we help find housing for her. So again, head, heart, hands. Every time we make a decision, every time we see a patient, best way to provide equitable care, and really it's the only way to provide the only way that we should be providing care. So that's the 3-minute version of that.
Wonderful. That's it's excellent stuff, and I want people to hear that because I think it's so important. So I think that if you can stop share there at the top.
I thought I did.
No, you stopped your PowerPoint, but didn't stop share.
Okay, there I go. Okay.
So I think I saw Colleen on there earlier, and I think that she's up for the case presentation. Is that correct, Dr. Howing?
Yes, I believe so.
Wonderful, wonderful. Okay, well, thank you all. For those that are going to stick around, great. For those that have to disconnect, we'll see you next week, and thank you for participating.